Hi, I'm Kim Eagle for ACC.21, and we're at the scientific sessions of ACC21. As you know, they're virtual this year. I'm delighted to be joined by Deepak Bhatt from the Brigham and Women's Hospital and Payal Kohli from the University of Colorado. The day is a Saturday, May 15th, and there's some major trials at this meeting that we want to talk about today. Saturday had 5 great trials that we thought were important to bring you information on. And we're going to start with a trial called LAAOS II. And Payal, give us your impression of this interesting study.
So Kim, I found this trial very interesting because really what we've been doing in practice for some time has been occluding the left atrial appendage at the time of cardiac surgery. And this trial really helps to validate, I think, what our practice has been. So it was left atrial appendage occlusion at the time of cardiac surgery, looking at the endpoint of stroke and systemic embolism to see if it was reduced. And it was 4,811 patients, high CHA2DS2-VASc scores of 4 and a follow-up of 3.8 years. And what they found was quite impressive, actually. There was a 33% relative risk reduction in the primary endpoint of stroke and systemic embolism, so a hazard ratio of 0.67. And then they also did a landmark analysis starting at day 30, so to really try to filter out some of the noise from the surgery itself. And they saw that the endpoint was reduced by 42% in the landmark analysis. They did a safety endpoint as well, looking to see if it increased heart failure incidence, which it didn't. And I was pretty interested to see that it didn't substantially increase cross-clamp time or bypass time either to go ahead and occlude that left atrial appendage at the time of surgery. So, I found the trial very interesting again, because it validated what we've been doing. It also showed that, it's reasonably safe to occlude the left atrial appendage. But most interestingly, perhaps, and still has me scratching my head, is the mechanism by which this type of left atrial appendage occlusion offers additional benefit on top of anticoagulation, because all of these patients were still treated with anticoagulation and their standard of care. What were your thoughts in reaction to this, Kim?
Well, I was impressed by the size of the effect, and like you, I was very impressed that the group that was on anticoagulation also benefited. That was quite striking to me. Deepak, any comments?
Yeah, absolutely, Kim. I mean, to me, this is a practice-changing trial. This is really one of the major studies coming out of this meeting, because I think it's immediately actionable. As Payal says, now, of course, a lot of surgeons have been doing this anyway, but there are a lot of things we're doing in medicine, and maybe even more so in surgery, that we're doing, but that aren't necessarily evidence-based. But now we have a concrete evidence base here to go ahead and close these left atrial appendages. And I think it does prove that there's value even in the patient anticoagulated, in terms of why maybe some of the patients on anticoagulants are going off the anticoagulants, even though they maybe shouldn't be, they're going off it for a while. And we see it all the time, even in patients where their INR is confirmed to be therapeutic, or we're confident they're on their NOAC, they still come in with a stroke with AFib, right? So there are breakthrough cases that are occurring. Stasis is occurring in that left atrial appendage, and anticoagulation may not always be sufficient. So I think when the surgeon's in there now, we should encourage them, if they're not already doing it, to go ahead and close that left atrial appendage off.
Yeah, I agree. The other part of it is that this was not just mitral valve surgery, right? These are patients having heart surgery. So CABG, aortic valve, aortic surgery. So to the extent that perhaps some surgeons were mainly focusing on this appendage when it was mitral valve surgery, for example, this, I think, is for that group of patients potentially practice changing. So one of the really important trials coming out of this meeting today. All right, let's move on. I love the name Atlantis. Deepak, tell us about this trial.
Sure. So great acronym, great group of investigators, great trial, nice design, executed very well. So basically, we're going after the important question of what do we do with all of these patients, the increasing number of patients getting TAVI? What is the correct antithrombotic regimen afterwards? It's been a source of a lot of controversy, discussion, lots of observational data showing thrombus formation on CT, on valves. Makes a lot of sense on the basis of pathophysiology then to anticoagulate all these patients. So what the study did was examine patients who have an indication for oral anticoagulation, like AFib or something, and randomize them to typical sort of anticoagulation, like with warfarin, or to apixaban 5 milligrams twice a day. with dosage adjustment if appropriate based on things like kidney function and age. So that is one particular stratum of the study. Separate from that, a second stratum was examining patients with no indication for oral anticoagulation. So they come in, they're in sinus rhythm, they get their TAVI. Should they be treated with apixaban 5 milligrams BID or with antiplatelet therapy? It could be dual antiplatelet therapy, could be single antiplatelet therapy. There's some discussion and controversy about whether it should be DAPT or SAP. This trial wasn't designed to address that. So what then was the role of apixaban in these two situations? And as it turns out, apixaban in the patients that had an indication for anticoagulation looked pretty good. And in fact, the hazard ratio was a bit lower than, say, the vitamin K antagonist, or I'll call it the warfarin arm, but not significantly so. So basically, it shows if you want to use warfarin, you can. If you want to use a NOAC, in this case, a dose-adjusted apixaban, you certainly can, but not necessarily any sort of clear-cut benefit from going to the NOAC there. On the other hand, in the patients who needed or who typically would be treated with antiplatelet therapy that didn't have an indication for anticoagulation, they're switching instead, or randomizing instead, to apixaban didn't provide any appreciable benefit. And with a little bit of a caveat, there was also a signal of non-cardiovascular mortality in the patients that were getting anticoagulated with apixaban without any real indication versus just being on antiplatelet therapy. So bottom line, if there's an indication to anticoagulate, do it whatever way you want to. These days, most often it would be with a NOAC, appropriately dosed. And if there isn't an indication for anticoagulation, don't just anticoagulate because you put in a TAVI. In that case, just stick with antiplatelet therapy.
Excellent. Payal, any comments from your point of view?
Kim and Deepak, I would say this has been so interesting for me to see, just because it's been a black box for so long. We have really sort of been making up our clinical practice as we go along. And I think this type of a trial really does, in a way, sort of, to Deepak's point, help us to kind of re-emphasize what we've been doing so far, which is that if you're anticoagulating, it is safe to use novel oral anticoagulants in patients that have an indication. The other thing that I found was interesting was that subclinical valve thrombosis was decreased with the use of these novel oral anticoagulants. Now, we've gotten very sophisticated at picking up subclinical valve thrombosis, but the clinical significance of this at this point, I think, still remains largely uncertain. So this study, I think, is a step in helping us understand a little bit better how all of those pieces tie together: the CT findings, the subclinical valve thrombosis, and the clinical outcomes.
Totally agree with you. Great summary of the art of this particular trial. There's a really interesting trial being presented today called Adaptable. Payal, I'd love for your impression of this landmark study.
So Kim, this was very interesting to me as well, because when I was a resident at Brigham and Women's Hospital, I remember every single person on the cardiology B team got aspirin 325. And more recently, of course, I've been putting all my patients on aspirin 81 milligrams. So this trial really asked the question that in patients with established atherosclerotic cardiovascular disease and at least one enrichment factor, such as kidney disease, diabetes, or smoking, which is better, aspirin 81 milligrams or 325. And what I found most interesting about this study, I have to say, more than even the outcomes and the results, was actually the way that the study was done. So it was a novel way to do clinical trials. They enrolled patients using an electronic medical record where patients sort of self-randomized themselves. And then they did follow-ups on the endpoints using ICD-10 data for the non-fatal endpoints. And then for the fatal endpoints, they looked at Medicare claims data and other insurance companies' claims data. And I think that novel methodology is really interesting because it's almost the clinical trial of the future in a way, using technology and the types of tools that we have in our offices every day to try to enroll patients and follow them up. So the clinical outcomes of the trial showed really no difference in the endpoint of death, MI, and stroke, or hospitalization for bleeding. We did, however, have a large number of people switching. So there were 24% of people that actually switched their doses, more switching occurring from the high dose to the lower dose, which I think also highlights one of the challenges of doing these kind of patient-driven or patient-centered sort of trials that we'll have to address in the coming years. But I think the bottom line here, the clinical message is that if they're on aspirin 81 milligrams, it's probably okay to continue that. If they're on aspirin 325 and doing okay, in other words, not having had bleeding, it's probably reasonable to continue that because it's not a lot different from the 81. But if you're starting an antiplatelet agent, probably 81 is a good one to start because it's got the same efficacy.
I totally agree with your analysis. It was really unknown whether a weight-based approach to aspirin dosing would have a beneficial effect. And I think this trial is very illustrative of what we should be doing, which is exactly what you suggested, starting with 81 milligrams. Deepak, do you have any comments about Adaptable?
I think it's just a fantastic trial. So from a trialist perspective, it's really brilliant design and execution. And this platform might allow us to answer a lot of these sort of important, relatively simple questions that we don't know the answer to. You know, what's the right dose of aspirin? So I think it's very informative, just the design of the trial. As far as the findings, I mean, I agree with what you both said. Basically, it's dealer's choice. If you want to use 81, use 81. If you want to use 325, you know, go ahead. I would just pull in the current OASIS 7 results. If you remember there, the randomized aspirin dosing did find a significant decrease in a randomized trial with essentially what would be equivalent to 81 milligrams of aspirin versus 325 for minor type of GI bleeding sort of issues. So in general, for chronic therapy, I think I'd still default to the 81, but you know, for some reason, a physician really wants to prescribe 325, I think that's probably okay for chronic therapy. Obviously, in the acute setting, you always want to give a loading dose of aspirin to the aspirin naive patient. You know, one thing that wasn't in the primary paper or supplement, but I think would be interesting, actually, I mentioned it to the PI, would be to look at enteric coating as well. I mean, that's the other part of things that have been under-researched. You know, does that in any way impact on the antiplatelet effect of aspirin? Might that be differentially more manifest, say, with a lower dose, 81, than a higher dose? So I think still in 2021, there are interesting and important questions about good old aspirin.
Yeah, go ahead, Payal.
I was just going to say, Deepak and Kim, I would ask you, do you think the high dose switching could have impacted the results, you know, just from a trialist standpoint?
Yes, I do. And, you know, I think they've done and probably will do more on treatment sort of analyses and so forth to really tease out, you know, potentially still some differences between the doses. But again, I think, you know, the high level message is probably, you know, there's no huge difference between the two doses, which probably makes sense based on the pharmacokinetics and pharmacodynamics of aspirin. So again,
Kyle, I wondered the same thing when I saw, I think 40% or so switched from the higher dose to the lower dose. And I'm thinking the bleeding rate was the same in the two groups. I'm wondering if some GI irritation or something led to a switch, which might have affected the bleeding rate from the higher dose.
Well, it's interesting because they said some of the reasons were medical reasons for the switch, but some of them, to Deepak's point, were that the physicians were switching them as well. But again, I think that the data got a little muddy, probably because of that high rate of crossover, and the bleeding is really what stood out to me, Kim, because how could it be the exact same bleeding on 81 and 325?
Yeah, we're on the same page. Let's move on. A really important study, EXPLORER-HCM, looks at this novel agent. Deepak, tell us about this trial.
Oh, sure. So what this trial studied was mavacamten. I'm not sure how familiar everyone in the audience is with this drug, though I think in the future cardiologists will be very familiar with it. But it's a targeted inhibitor of cardiac myosin, and that ends up reducing the number of myosin-actin cross bridges that form, and that then decreases contractility, which in a patient with hypertrophic cardiomyopathy, we know is a useful thing to do. And you know, the main results from EXPLORER-HCM have been presented. What this analysis that Dr. Spurt has presented looked at, I think, is super interesting. In some ways, it's probably even more important than, you know, just looking at different echo or other biomarker parameters and judging efficacy. What he and his collaborators did was look at the Kansas City Cardiomyopathy Questionnaire. I imagine many people in the audience are familiar with it, but if you're not, it ranges from 0 to 100. Higher means fewer symptoms, so higher is better. And it's looking at quality of life, function, that sort of thing from a patient's perspective. And bottom line is there was a significant improvement in the Kansas City Cardiomyopathy Questionnaire overall score with mavacamten versus placebo. So that is important, it's positive, but what I think is more informative is the magnitude of difference. The difference was 9.1 on the score. That might not mean much to people but just trying to contextualize that, as Dr. Spertus did in his presentation, that's a pretty big difference. So compared to other sorts of practice-changing heart failure trials, things like DAPA-HF, for example, it's a larger difference. So that means these patients who were symptomatic, of course, from their HOCM, really got a lot better. So beyond improvements in echo parameters like LV outflow tract gradients or biomarkers like BNP or anything like that, patients are feeling better in a randomized placebo-controlled trial. So to me, for patients with HCM, this is a real win for those patients.
Totally agree with your analysis. It's it's really a blessing to have this quality of life study on top of the study that really looked more at physiology. And I was impressed by the notion that I think 36% of the patients who got the drug reported major improvement. That's like an NNT of 3 to get major improvement. So this is really going to change the way we care for these patients. Payal, do you have any comments about this particular study?
I would just say a couple of things. The first is that we give our patients a lot of medications that help treat us. They help treat the outcomes, they help treat us, but they may not make the patient feel better. So I think this is a really nice study demonstrating something that actually improves the patient's quality of life. And I think that's so rewarding, obviously for us as providers, but also for the patient to take this medication, feel better. The second is that to your point, Kim, not only was there a large improvement in some of the patients, but we also saw that they regressed with treatment withdrawal. And I think that that's kind of the ultimate evidence that that drug is really doing something to improve their quality of life in a very difficult to treat disease, otherwise, obviously genetic condition with lifelong implications. So I was really happy to see this study.
Yeah, great study. So let's finish today's trials by looking at Paradise. Payal, give us your thoughts about that trial.
Yes. So Paradise MI was essentially, a trial looking at the use of ARNI, so sacubitril/valsartan combination therapy in patients who've had a recent, acute MI and have reduced ejection fraction with evidence of pulmonary congestion. And I think the scientific rationale for this really comes from the impressive effects of an ARNI in heart failure with reduced ejection fraction. So the question here is really, if we move the therapy upstream, we do it during the hospitalization when they have their acute MI, their EF is down, they have pulmonary congestion and additional risk factors, are we going to modify their outcomes? So it was a sacubitril/valsartan versus valsartan alone, and looking at the composite endpoint of cardiovascular death, heart failure hospitalizations, and outpatient heart failure requiring therapy. And the follow-up here was 23 months. And really what they found was actually no difference. It was not statistically significant. So you had fewer events in the treatment arm, sacubitril/valsartan, compared with valsartan alone, but it did not achieve statistical significance. But Kim and Deepak, what I found most interesting was that when they looked at the total event analysis, so not just looking at the first adjudicated endpoint, but all the events at the same primary endpoint, they did find a statistically significant reduction. So they had a rate ratio of 0.79 with a p-value of 0.02. And then interestingly also, if you look at investigator reports of the first endpoint of that cardiovascular death, heart failure, hospitalizations, and outpatient heart failure, they found a hazard ratio of 0.85. So to me, the most interesting thing about this was perhaps we were underpowered for the duration of the treatment and the number of events that we had to detect a difference in just the first endpoint, which was adjudicated. However, we did detect a difference in the total endpoints as well as the investigator reported endpoints. So I think this raises some interesting questions about clinical trials in general. And should we start looking more often, regularly at total endpoints as Dr. Bhatt and others have done? What do you guys think?
Deepak, what do you think?
Well, I'm a believer with respect to total events analyses. I think, for many trials, not every trial, but for things like heart failure related endpoints, atherosclerotic endpoints can be really useful. In an AFib trial, maybe not so much if, there's a sort of change from randomized therapy to open label therapy. Where the contrast between the two treatment arms will be maintained for the whole trial, that is drug versus placebo, I think it's really the way to go. And I think you're right. I mean, I think that, there were positive signals in here. So, of course, a purist is going to say the trial didn't meet its primary endpoint, it's negative, end of story. But, I think that there's value in looking at subgroups. I think there's value in looking at secondary endpoints, especially for a drug that's already approved, where there's already been one clearly, or a couple of clearly positive trials, maybe another one kind of with a mixed message like this one. So I look forward to further analyses from this, so we can really tease out whether this specific drug in this setting, should or shouldn't be used in select cases.
Yeah, I felt the same way, Deepak. I think the drug probably works. The effect size was just not quite enough to reach the statistical targets that they had, but the sense is that it's probably relatively safe, and there may well be subgroups in this category where there's substantial benefit, and we need more science to guide us there.
And I think the silver lining of this trial, what stood out to me is just the low overall event rate, compared to other trials that in the 90s and the 2000s. And so really how good we've gotten at treating patients in the hospital setting as well. I think that was really positive.
Excellent. Well, we've covered a lot, 5 terrific trials from today's meeting, ACC21. We talked about LAAOS, we talked about Atlantis, Adaptable, EXPLORER-HCM, and Paradise, all trials that I think are informative. We want to thank our learners for listening to the excellent analyses by Payal Kohli and Deepak Bhatt, and we hope you enjoy the rest of your day. This is Kim Eagle for ACC.org, and we're out.